All right, let's dive right in. Welcome back to our Evaluation and Management Explainer series. Today we're on part 14, and we are officially setting aside the theory to get our hands dirty. We're going to walk through a highly practical, step-by-step clinical case deconstruction. If you've been following along, I know you already know the EM guidelines inside and out. But applying them to a real-world chart, well, that's where the true art of medical coding and auditing actually happens. So, grab your notebooks because we're going to audit an established patient encounter from start to finish using the medical decision-making, or MDM, table.
Here is our agenda for today. We'll start with number 1, the clinical patient encounter. Then we'll cover 2, Chart A, problems addressed, 3, Chart B, data reviewed, 4, Chart C, risk assessed, 5, final MDM code selection, and 6, key takeaways and a teaser. Let's kick things off with Section 1, the clinical patient encounter. Okay, so here are the clinical clues we're working with today. We've got an established patient, a 35-year-old female, coming in with a 4-day history of dysuria, painful urination, lower abdominal discomfort, and urinary frequency. Importantly, though, she has no fever or back pain. The provider suspects an acute uncomplicated UTI. But here is a detail you absolutely cannot miss. The patient's mother is actually providing the supplementary history because the patient has a developmental delay. The provider uses the mom's statements to assess the baseline and how the symptoms are progressing. Moving on, the provider orders a urinalysis and a urine culture. Finally, after checking out the lab results that confirm an infection, they prescribe a 5-day course of oral nitrofurantoin, give some counseling, and set up a follow-up plan. Section 2, Chart A, problems addressed.
To figure out our score for Chart A, we need to match this diagnosis up with the AMA guidelines. Now, the guidelines define an acute, uncomplicated illness or injury as a recent or new short-term problem with a low risk of morbidity where treatment is considered. Essentially, there's little to no risk of mortality with the treatment, and we expect a full recovery without any functional deterioration. A standard UTI fits this like an absolute glove, right? It's new, it's short-term, and with a basic round of antibiotics, she's going to fully recover.
So that exact definition locks in our very first score. On our MDM scorecard, Chart A, the number and complexity of problems addressed is securely categorized as low complexity. It's not minimal. It does require treatment and an evaluation way beyond just a simple nurse visit. But it definitely doesn't cross the threshold for moderate, which would be something like an acute illness with systemic symptoms. So low complexity it is. 1 column down, 2 to go. Moving right along to Section 3, Chart B, data reviewed. Let's deconstruct the data points from our provider's note, because this is where folks often get tripped up. Under Category 1 for data, we sum up the different elements. First, the provider ordered and reviewed a urinalysis and a urine culture. Since these have distinct CPT codes, they count as 2 unique tests. That gives us 2 points. But wait, look at the other side of the equation. Remember the mom? The provider specifically documented that an independent historian, the mother, was required to get the history because of the patient's developmental delay. The guidelines are super clear here. When a patient can't provide a complete history due to a developmental stage or condition, and an independent historian is medically necessary, boom. That counts as a distinct data element in Category 1. 3 is the magic number for Chart B. We have 2 unique tests plus 1 independent historian. When you sum up those 3 distinct elements, it firmly meets the criteria for moderate complexity data. Just to recap, to hit moderate in Category 1, you need any combination of 3 elements from that list of tests ordered, tests reviewed, notes reviewed, or independent historians. By combining the lab tests with the mom's vital contribution to the history, this documentation easily clears the hurdle. Checking our scorecard again, we now have our first 2 pillars locked in. Chart A is low and Chart B is moderate. We're halfway home. Now we just need to figure out the risk level based on how the provider actually decided to treat this patient. Section 4, Chart C, risk assessed. Let's see exactly what the guidelines tell us about risk. The source document literally says, prescription drug management, starting or adjusting medication that requires monitoring, falls under moderate risk. It's so important to remember that assessing risk isn't about crunching exact mathematical percentages. It's entirely based on the provider's clinical judgment, the problems they're treating, and the specific decisions made during that visit, like, say, starting a new medication. Connecting the dots back to our specific case, our provider didn't just tell the patient to go home, rest, and drink some cranberry juice, right? They reviewed those labs, confirmed the infection, and actively prescribed a 5-day course of nitrofurantoin. Prescribing a new systemic medication to treat an acute infection, that is the absolute textbook definition of prescription drug management. Therefore, this specific management decision automatically elevates the risk profile of this encounter straight to moderate risk. All right, we've systematically deconstructed the whole chart. Under Chart A, the acute, uncomplicated UTI gave us a low problem. Under Chart B, the 2 tests plus the independent historian gave us moderate data. And finally, under Chart C, the antibiotic prescription gave us moderate risk. Low, moderate, moderate. We've got all our puzzle pieces. Let's put them together. Section 5, Final MDM Code Selection. To determine our final medical decision-making level, we have to follow the absolute golden rule of E&M coding, the 2 out of 3 rule. Step 1, we list the scores from our 3 charts, low, moderate, and moderate. Step 2, we drop the lowest element. So we say goodbye to the low score from Chart A. Step 3, we look at what's left. We have Chart B at moderate and Chart C at moderate. Because 2 out of our 3 elements meet or exceed the moderate threshold, our overall medical decision-making level for the entire encounter is officially moderate. Now, we just take that moderate MDM level and apply it to our patient status. Remember, from the very beginning of the case, this is an established patient in an office setting. For established patients, a moderate level of medical decision-making lands us perfectly on CPT code 19924. If this had been a new patient, sure, it would have been a 99204. But here, the provider fully justified billing a 99224 based entirely on the complexity of their clinical reasoning, the data they synthesized, and the risks they managed.
Section 6. Key takeaways and a quick teaser. Here is what you absolutely must take away from today's explainer. Number 1. An acute, uncomplicated illness like a standard UTI is a low-complexity problem, even if it feels routine. Number 2, and listen, this is a massive area for missed revenue and compliance issues. Do not ignore independent historians. When a provider uses a parent, guardian, or surrogate to get the history because the patient can't, that combines powerfully with order tests to boost your data score. And finally, simply prescribing a new oral antibiotic equals prescription drug management, which automatically triggers a moderate risk level. Sticking to these 3 rules ensures your EM levels are always accurate, defensible, and fully optimized. Before we wrap up, I want to leave you with a bit of a provocative question. In this case, the MDM drove the code beautifully to a 99214. But what happens when a provider spends 45 grueling minutes counseling a patient and coordinating care, but the actual clinical problem only scores as low on the MDM table? Do they just lose out on all that hard work and time just because the medical decision-making was straightforward? Well, that exact dilemma is what we're going to solve in our grand finale. Up next is Part 15, Practical Case Study 2, Optimizing MDM versus Time. We're going to show you exactly how to toggle between decision-making and time-based billing so providers get fully reimbursed for their effort. You are not going to want to miss it. Until then, keep auditing carefully, keep learning, and decode healthcare with Harshal.